Welcome to the Endo Files. I am coming live from the AAE trade show floor with Dr. Bruno Azevedo. Bruno, how are you doing?
Kim, really nice to be in here. I love this show. It's been awesome being together after a couple of years. So couldn't be more excited.
So happy to have you here. I am glad that you allowed me to pull you off from all your adventures I know you were slammed here at the AAE. What all do you have going on?
Yeah, so we have some lectures. I actually did two lectures back to back yesterday, together with Dr. Lars Gallus, which is a radiologist from Minnesota. Was great. It was a uh, counterpoint sort of situation, and the response was really good to have two radiologists talk about imaging and endodontics and with different views was very interesting. Uh, of course, I'm here at the U.S. Endo Partners booth,
And we're grateful.
talking to residents and doctors about imaging and excellency in diagnosis. And tomorrow, I'm doing two 4-hour lectures, hands-on courses on imaging. So one basic course in the morning, one advanced course in the afternoon. So
And that's a day. That's a long time to lecture. So yeah, I know that the endodontists are greatly benefiting from having you come and teach them though. You are spending some time with US Endo partners, just basically going around to our doctors' offices and helping them and their teams um, just understand what they're seeing, understanding things that they're missing, getting things set up in their office. What are some of the biggest takeaways that you've seen our doctors learn when they're in office visits?
well, that's kind of a deep question. I'll tell you that it's very
Well,
deep.
let's go deep,
Let's go
Bruno.
deep. But I'll tell you this: when you're having those sort of a deep conversations, I'm a strong believer that those conversations flow a little bit better with bourbon. Okay.
They always flow
So,
better with bourbon.
so because I live in Louisville, Kentucky, I brought bourbon. But check this out, guys. So you guys online don't have to worry about. We're not going to be drinking bourbon. We're going to be eating our bourbon today. So I brought some bourbon balls for you,
Oh my gosh, thank you so
and
much,
this is actually
Bruno.
chocolate made with bourbon. So we can have a sweet conversation and have a
I
little bit of bourbon.
I'm digging right in. I'm
I
gonna
know, I know. So Kim
chocolate
is
and
actually,
bourbon are two things that go, and Blake is going to be my husband,
I know.
as you know. He's going to be very jealous because he loves bourbon balls. So he's going to be ticked off that he doesn't have any, but that's okay. Maybe I'll save him
Yes.
one.
So there you
This is
go.
awesome. I am so I love that you did this though, because in my podcast that I do regularly off the show, you know me very well. You know my favorite thing to do is sit and have a drink with people and chit chat all day. So normally when you're a guest on my podcast, which I want you to come back and be one on the regular show, not the live version, but we sit down with your favorite drink and we sip a drink together and we have a conversation.
That'll be
So
awesome.
we're not sipping today, we're eating.
We're
But
eating bourbon today. That's awesome.
we're eating bourbon balls. This is awesome. Oh my God, they look so good. So
Yeah.
I will wait till I'm not talking to eat those. So
All right.
anyway,
So going back to your question, we've been working together now for almost 8 months, and it's been a very symbiotic relationship of having a radiologist that has a heavy interest in endodontist to see the everyday uh, imaging needs of a dental practice. So what the takeaways that I have that I've learned over all the things that I've done for the company in the last few months is that um, there is a lot of hunger for information related to imaging because there's not a lot of resources that allows doctors to train staff, to enhance their imaging and therefore their diagnosis capabilities. There's a lack of that space everywhere, and there's also a lack of information on how to achieve some of the desirable things that those doctors want. And when we got together, and we were discussing, what I was going to do for US and the partners, this was the priority. It was like, let's help those guys. Let's make sure that they can drive their imaging and their imaging protocols to the top. And it's been fantastic to go back to those offices, visit them, see their workflow, and come up with suggestions on how to do things a little bit better, a little bit faster, and improve their diagnosis and therefore make their practices more efficient and their workflow more efficient, and also to allow those doctors to better understand imaging and see more fractures and see more, whatever findings that they are looking for, because their image quality gets instantaneously better. So that's been phenomenal for every practice that I visit. I was actually just talking to a doctor uh, right before here, and he came to me and said, "You changed my life." And I was like, "What do you mean I changed your life?" And it was like, "You don't understand. Like, when after you came to my practice, it's like you turn on the lights on my unit. Now I could see things that I always knew I could. I just didn't know how." So that was, it's very nice when people come to you and
I was
say,
to say
"Man,
that's got
you,"
to make you feel
yeah,
good.
it makes you like, okay, the job is being done and it's awesome. And also with the staff, when you come in and you train the staff and they go, "Wow, this is awesome," because the person that trained me was the person that used to work here 2 years ago, and now she's left, and that's the only information I ever got. And then you educate them, and suddenly you can see the light bulbs going on, and because now they get it. So I'm a strong believer that you can be very good knowing how to do things, but you can be much better if you can understand why you're doing that. So what we introduce to the practices is why we do things a certain way. And as they understand that why, the what, right, which is the diagnosis, now becomes what has more purpose. And that is what we have done over the past few months.
That's fascinating. I know all of our doctors, every single one of them have expressed gratitude coming back to like, it's totally changed my life. This is the best thing I've ever done. Oh, and we have David Landwehr who is make interrupting our whole conversation. And get a shirt. Yes, absolutely get a shirt. We have tons. Um, but he anyway, all of our doctors have expressed gratitude, and dude, they talk about how it's changed their lives. And what's even more interesting to me, there's a story, and I'm not going to mention a practice that happened in, but when you were coming in, the staff, the team that supports the cone, the imaging and the cone beam process and everything, they were a little perturbed coming in because they were like, we know what we're doing. How dare this guy? Who's this guy coming in? Who's the cone beam guy that's coming in and thinking he's going to change what we're doing? We can teach him a thing. We're the ones that do this every day. And when you left, they were like, oh my gosh. Like, I think they were even putting the apron on backwards, and like they weren't positioning the mouth right when they were doing the imaging. All this, just all these little tweaks of the process that made the imaging so much better. Not to mention what you actually do to the machines that they're working on, depending on which cone beam they're using. You make tweaks so that they're seeing things like that too. But just making a difference. And they came back afterwards and were like, I hate that we said that because we learned so much from this guy and it's amazing. So it's always good to be open minded. But anyway, you're really helping teams, the whole team in the endodontic practice, to help their patients and make it easier for their patients and get better care. So anyway, it's been a great process. So you have not, radiologist, right? Not always an endo, not always a special, what I would call a specialist in endo, but it's a love of yours. Let's talk about that.
So, my story is like this. I was born in Brazil, and my dad is an oromaxillofacial radiologist, just like me. And my dad was in the imaging center business in Brazil. So we lived in the capital, Brazil, Brasilia, and we had a couple imaging labs. So in Brazil, it's very common for dentists to refer their patients out for imaging instead of buying their own units. So my father had two imaging centers in Brazil, and in 2003, believe it or not, we bought our first home beam CT scanner. So I've been using this. You do the math here for 19 years. Uh, what happened was when my father bought the first home BCT scanner for our practice, it was a small field of view, high resolution unit. We bought an Aquitomo at the time, and the Aquitomo had a field of view of 3 by 4. So the father of high resolution imaging, Dr. Yoshinori, arrived from Japan. What he used to say was he created a machine to substitute a periapical radiograph. That's why the field of view was 3 by 4, the size of a periapical radiograph. So right in the beginning, I started my career with small volume, high resolution scans, but that's the protocol that we use today. So that's all I knew. And 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 within the first week I was working with that unit, I suddenly realized that there was a lot that we were not seeing on 2D. I thought it was pretty good with two-dimensional imaging and panoramics until I start using that thing and going, wait a minute, there's a lesion here, and I'm looking at the period radiograph, and there's nothing there. What's going on? And suddenly it just clicked that a lot of the patients that we thought were crazy that were coming in and say, hey, this tooth hurts, and you look at it and nothing is there. Suddenly the information is right in front of you. You just couldn't see it before. And right away I started to notice, oh, look, there's a canal here and there's no endodontic fluid material within. And that's why this guy has pain, but the PA doesn't show that. Um, so we start to better understand and appreciate the nuances, right? The things that make endo the greatest specialty that is, because for the first time we were seeing this. So I was never a fan of endodontics. I never enjoyed. I went to dental school. I could care less about endo at that time. But then suddenly, when Combine arrived, that's what made me become very interested in that. And then suddenly you start to see a fracture now. All those invisible things that we can see before. And naturally, because that was my environment, that's what my private practice was, I started to navigate towards this and started to talk to endodontists. And I'm going, guess what, you guys are gonna start using this. It's gonna be great. And for the past, again, 19, 18 years, I've been telling every single endodontist, the moment that I saw the first time, I was like, guys, this is going to change your specialty. This is going to be the gold standard.
So you're the
Very
one that
first,
started this whole movement.
for definitely one of them. So, and then, since I moved to the US, I used to tell endodontists, um, all the time, even when I was in San Antonio, was to say, hey guys, you guys are going to buy this, and you guys are going to have this on in every office, and you guys are going to use this on every case. And I remember some very prominent endodontists at the time telling me that I was crazy. It was like, this is too expensive, we don't need it, blah blah blah.
The
And
radiology,
who are you to be saying all those things? It's like,
yeah.
guys, I know I'm just a dumb resident here, but just wait. And sure enough, after 20, after 15 years, look where we are today, right? Where everything is being driven now by advanced imaging. So if you think about every single one of the newest technologies that we have on the market, with perhaps the exception of lasers, quantum beam CT imaging, it's mandatory before you want to use it. So if you want to use dynamic navigation, what do you need? You need cone beam CT imaging. You want to do surgical guides. What do you need? Cone beam CT imaging. You want to run gentle wave. What is gentle wave's recommendation? Do a cone beam before you run gentle wave. You know, so it's part of endo, whether you want it or not. And right now, I feel that we're going to have even further use of cone beam CT imaging moving forward in order to better analyze outcomes, because if you think about it, every single major study on outcomes has always been done in two-dimensional imaging. And if two-dimensional imaging has the flaws that we know that they have an imaging analysis perspective, that means that those studies are not really quite correct. So the only way that we can now have a better understanding on outcomes will be to look at databases moving.
Well, and I'd have to think, talking about outcomes, part of part of this is knowing when not to do the endodontic treatment now, because if you do it, you're going to have a failed outcome. So I would be thinking that with cone beam integration, your success outcomes goes up. You know how to better. You're not missing canals. You're not feeling. You're not if there's a crack that you didn't see before, but now you know it's not. There's nothing we can do. It's not. Let's not spend the money here. Let's refer it out. So the increase in our success rates have to be going up, which were already good anyway. But it's got to be a game changer.
It is going to, that is, you're absolutely right. When you talk about the fact that case selection now, it's way better than it was 15 years ago. Of course, we have at the same time better armamentarium that allows us to try to save teeth today that 15 years ago we would probably condemn. So there's like two sides to this equation at the same time. But the most important thing, I believe, about imaging is that if you have an Adonis out there, you imaging will humble you a little bit. And what do I mean by that? sometimes you think that you did a great root canal. In two-dimensional imaging, it looks like a great root canal, but when you look in 3D, there's some flaws in there. And what I've learned from some of the partners, for example, I had the pleasure to lecture with Scott Doyle in Brazil. I invited him to come down to Brazil and lecture with me. And at that time, my boss from Louisville, from the University of Louisville, where I used to work, Dr. William Scarf, again, the guy that wrote the book on cone beam CT imaging, um, was with us at the same meeting, and he wasn't a believer on a cone beam on every case until he saw Doyle speak, and this is what Doyle said, which was awesome. He started the lecture showing 5 retreatment cases. They were all first molars. Then he showed 5 different conditions of the treatment on 5 molars. So, he said, oh, we did this, there's a middle mesial canal here, there's this here, blah, blah, blah. So imagine 5 different cases, scenarios. And then he shows the cone beam and going, okay, see, now I have the diagnosis to retreat this. This is why it's failing. This is the retreatment. Now this is the cases healing. So he shows this 5 sequence. And after he finished those 5 sequence, he asked the audience, so what do those 5 cases have in common? And everybody went, well, yeah, those are 5 retreatments of first molars. And he goes like, no. What those 5 treatments have in common is that I was the endodontist that did the first root canals, and I chose not to use cone beam CT imaging in those cases. So he was observing his own failures and understanding why he was missing stuff. And then after that, he just realized, why am I not doing this on every case? In that moment, Bill Scarf looked at me and was, I get it now. I understand it now. You cannot live without this. So yes, so that was a very powerful moment. And again, everybody that's out there, if you can have the chance to evaluate your work, see how it's healing in 3 dimensional images, you will learn so much about the biology of the of the body. You're going to learn a lot about your own beliefs, and you really want to know if it's working the way you think it is. See it. What's better proof than actually seeing it live in front of you, right?
Yeah.
So
It takes the what's the I can't remember the title of the course that you do, but it's
the unknowns
seeing
unknowns.
it takes the unknown to the knowns. Now you're seeing the unseen before. So it's and you can and you know that it's progressing and making a difference and doing the things. That's amazing. Yeah, it's amazing. So you're saying use cone beam on every case. I know a lot of endodontists who are like, I don't use it on every case. I don't need to use it, but now I know when I need to use it. I don't know. So to this point, something that should be a simple, straightforward root canal that any endodontist can handle was failing, retreating because he did not, or she, I don't know if it was he or
Yeah,
she, but because they did not use
combing,
cone beam.
because there's
So
information missing. So this was actually my lecture yesterday. It was explaining why you should use cone beam CT imaging on every case. And the cool part was everybody that attended the lecture left the lecture going, yes, I'm going to start using it on every case now. You convinced me. And it's just very easy to think about it. There's no such a thing as a straightforward root canal. There's no. That's a very wrong perception, because dental anatomy is complex, whether you want it or not. And the idea that 2 dimensional imaging by itself, it's enough for you to understand the complexity of that anatomy, this is a wrong mentality. So if you have access to 3D imaging, there is absolutely no justification in the world today for you not to use it. The barrier is you. So the conversations that we had yesterday was, we proved with literature that yes, you have a benefit every time that you take a scan. And one thing that's a misconception, Kim, is that if the cone beam didn't change the treatment plan, that's a waste of time. So that is a wrong way to see it. A negative diagnosis is still a diagnosis, so it doesn't mean that you have to have a finding there for not to have value. The fact that you just take a scan and it is what you think it is, that has a lot of value on that.
validation.
Validation is just all that is, right? And then the second component that was very interesting yesterday, it was the talks on dose and radiation and the fears, and and the ambiguity of a lot of those papers talking about dose and probability of cancer and things like that. So what I did yesterday, I showed up Who write those papers? So basically, I started to show, listen, people that are writing those papers, they are just echo chambers for really bad research. So what is very interesting to me is to see a bunch of papers in endodontics talking about risk of dose, and you have to be careful, and principles of Alara and things like that. Uh, and you look who wrote those papers. Who are the experts that are writing this? And they're all endodontists. And I'm sorry, those people have absolutely no qualification to make such statements. I cannot, me as a radiologist, I will never go in and talk about what should you be doing in endo because I don't have that expertise. But somehow that space gets invaded by other opinions. So what I did yesterday, I was like, well, you guys are reading all this stuff here on dental literature, but I'm going to show you what actually the medical health physicists are talking about. Right? Let's talk about what the biggest organizations in the world of radiation physicists are talking, and radiation biologists are talking, and the Nobel Prize winners are talking about, and let's correlate what the top of the food chain of knowledge is. And I'm talking about journals like Nature, and they have like exponentially more penetration in science than even the JOE, right? And let's compare what those researchers are actually talking about to what this nonsense of low dose radiation in cancer talks about. And after everybody saw what I was presenting, and how some of those concepts, they are just fundamentally wrong. They've been wrong since the 1950s and somehow keeps coming back. They were like, oh my god, how come we don't know this? And I was like, well, the reason why you don't know this is because nobody here reads the Journal of Nuclear Medicine or the Journal of Health Physics. I do.
Right.
Because
So listen to people who do
to
read
do
those
read those
things.
things. So those are the so those are the best research that we have in the world to kind of put peace of mind. Cone beam CT imaging has no pathway to harm. You cannot give cancer with patients today with cone beam CT imaging. It's biologically impossible. So yes, you can use it very safely.
Okay, I want to hear that again. You cannot give cancer to people through cone beam imaging.
You can't do
That
it.
is a pretty direct
Yeah, it's a direct.
statement.
It is a direct statement because that's what research has always shown. You have 60 years of epidemiology studies. You know what we don't have? One case, just one. All I want is one case that can somebody say, "Oh yeah, this patient got cancer because dental imaging was done." It's zero. It's always been zero. You can't. It will be equivalent like this. Have you ever learned anybody came in your lifetime that went to Vail for a weekend vacation to ski and came back with cancer from Vail? No, but that radiation that would get in there would be exponentially more than radiation from a
Than
cone
what
beam.
they're getting with the cone beam.
Now, let me ask you this. If you go to Vail, there's a population that lives there, right? That population that lives in Vail, that works there all day long, all year long, do they have more cancer because they live in Vail than, folks in Texas or in New York or in Los Angeles?
I would not think so. Unless they might if they're outside more, I
They
guess.
don't.
If they're getting
It's the same thing. There's absolutely no more, no less. And this is throughout planet Earth. We don't have this homogeneous dose on everybody on planet Earth. The whole planet Earth is very diverse on where you live and what you're exposed to because conditions are different. So the place on planet Earth that you have the highest radiation dose to the population to a population is actually in Brazil. And just to give you an idea, it's almost 100 times more than what the average American receives every year just leaving the United States. The population of that area in Brazil has the same amount of cancer as every population in the world.
that is mind blowing
It
to
is.
me.
So again, it's very interesting to see how this is going, and when you actually show the evidence, it doesn't support the fear that we have, and to have this roadblock in front of you that prevents you from the knowledge of doing the best root canal you can for understanding this very complex anatomy that we're going in every day. So that's a very important sort of a topic. So it was great yesterday. So anybody can go back and watch the recording at the AE. The lecture was recorded, was transmitted live. The feedback has been fantastic so far. So I welcome everybody to go back there and see what I was.
Absolutely, everybody should. Anytime any of yours that they're recording, they should go back. Anytime I've talked to you, anybody I know has talked to you, just in the conversation alone, learn so much that contradicts prior learning. Which you make such a good point too. It's trust the specialist. As endodontists, endodontists want people to trust them as specialists, and we're doing everything we can to build that relationship. And it's the same here. Trust the specialist and listen to what they're doing because they have the knowledge and the research and all the things that, and be open minded. Be open minded because that's one thing I've learned working with in the endodontic industry over the past 23 years is literally contradictions everywhere in research and conclusions that can be drawn even from a paper that didn't even show up in the research. Like it's like so you have to really dig in and understand where things are coming from, who wrote them, why they wrote, what their biased opinions might be, and really try to go to the root source of everything.
So
But
when we were doing the point counterpoint yesterday, that was actually the point. I was like, guys don't need to believe what I have to say. I'm just going to present to you what the best, information that I can present. What is the evidence base that I have to come up with my opinion? And that's what I did. I just presented that, and then I was trying to compare and contrast that with, some of my quote unquote, counterpoint colleague was trying to do, and that everybody kind of you know take their own conclusions, that perspective. But the idea that you're holding yourself back on imaging uh, because of the fear of cancer and so on. It's just not justifiable today. This is a problem that I really wish we could tackle the way the AE tackled that movie, Root Cause.
oh, the root cause, yeah.
So it's almost on the same grounds at that. When that came along, and Root Cause was a was becoming a thing. I was telling you guys, welcome to my world. This is what I have to do every day with what I do, because there's so much misinformation out there, and this irrational fear of what I do, when you should be embracing it. And it's the same thing with endodontics when that came out. So it's a similar thing. It's going to take a little bit longer to get there, because that fear it's really embedded in society right now.
I was gonna say it's not even the doctors. It's probably patient generated too. Because as a patient, you're like, I mean, you're gonna have your people who no radiation. They don't want any exposure to anything. And how could we, like, don't do anything that's
Sure,
unnecessary.
it's because, again, you're absolutely right. We It's much easier to sell fear than comfort. I'll tell you this. So it's always about, be fearful of your dentist, be fearful of this, right? It's never about, look at the positive changes that we're doing. Look at the fact that we are, taking away infection from your tooth, and that infection is in your bloodstream, and it's impacting the way you eat and the way you sleep, and those are the true things that have an impact in your health. So somehow, somewhere, the cure became worse than the disease, and that's not true.
And it's interesting that you say that because as a patient, like, I think people can get caught up in they're there to be taken care of. We don't need to tell you anything. We don't need to educate you as the patient on anything. We're just going to do this thing and trust us. But because of the lack of information and the lack of time of explaining why, to your point earlier, when you start sitting down with your patients and telling them why, I'm one of those. When I understand why you're doing something and how it's going to help me, and you take the time to explain it and get me comfortable with it, I appreciate it. I value my doctor more, and I feel even more confident and comfortable in their hands. But when they kind of keep things from me and just let me make those decisions without addressing the misinformation that I might have, things I don't know that I'm not educated on. Because you know what? As endodontist, you're reading the JOE. As a patient, I'm not reading the JOE, or I can't even remember the name of the other journal that you referenced. I'm like, we're not educating ourselves in that way. So we expect you all to do it for us. So I think arming, like as the specialist going to the patient, speaking from the patient's point of view, we are looking to you to help us get over those things and do what's right for us. We need the guidance. So they should be armed and confident in presenting, not feeding into the fear. So it's interesting. Uh, So I want to shift gears for a little bit because you are taking on you're embarking on a new journey in your life. So you are the combing guy, and you have been aiding and assisting endodontists for a very, very long time, and you've changed the landscape of endodontics with your knowledge, and you're gifting it to us and all these things. I mean, you have been such a vital role in helping endodontists do better things. You are now going to become an endodontist.
I know, right?
You're crazy. You're going back to more school. What? Tell me about this.
So, for those who don't know, Kim is I call Kim my godmother. And the reason for that is because Kim gave me an opportunity about 7 years ago to come to an event and lecture to a very select group of endodontists at the time, and pass this message that that I'm always been talking about to an audience that would have more impact. I'm going to put it this way. And ever since that opportunity, that's when folks have started to pay attention more to the message that I have to say, and some of this, something, and pay more attention to imaging. So again, thank you for that. So for those who don't know,
Well, you're.
a lot of where I am today, I wanted to keenly say
I
so.
will. I will say you're welcome, but you're here because of the content and who
Yeah,
you are.
but
I just gave you a platform for a minute,
yes.
and you took perfect advantage of it
Oh
and
yeah.
had a good message, and
So
that's why you're here. So
appreciate that. But going back to your point, yes. So after 22 years of radiology, 19 years of a career dedicated to cone beam CT imaging, I decided to go back to school and become an endodontist. I really did. So why? It's very simple. I decided to pay attention to what I was paying attention to. It got to a point now for the last at least 4 or 5 years that everything I do, it's endo. Although I don't practice endodontics, but the research that I read, the stuff that I'm Googling, always has to do with endo. So I have totally immersed myself into this specialty for the vast part of the next 10 years or so. And it got to a point now that I crave what my colleagues are doing. I know that when I lecture to an endodontist, they are always craving what I know. They want to understand, what's going on through my brain when I'm looking at an image, and how do I know this is X or Y and things like that. But what they don't know is when they're doing they're doing their treatment and they're doing a surgery and they're seeing blood or pus or whatever. I crave that as much as they crave my knowledge, and the reason for that is as I've never touched it. So picture this: I've taught tens of thousands of people on how to find an MB2 on a calcified canal or things like that.
right.
You know what I've never done? I never put a file in there. So it's time for me now to experience the other side of the coin. So I'm very, very grateful with the opportunity that I got from Dr. Fred Barnett and Einstein to accept me
Absolutely.
as a resident. And I am going now to kind of dig in and kill the hunger that I have for this knowledge, or this clinical knowledge, and combine that with the skills that I currently have with my, with it being a radiologist. So
Yeah.
it's going to be fantastic. I'm really looking forward to this transition. I think it's going to strengthen the specialty a little bit more, because you will have somebody with a lot of knowledge in one area, but now dangerous enough in the clinical side, and see what we can do together. So it'll be fun.
I can't wait to see where this is going to go, because I agree with you. I think your perspective that you already bring to endodontists, you're very ingrained in it and engrossed and know so much. But what you'll learn there and bring back, and then your perspective, I will say this: we're worried for a minute. You're going to be out of pocket for 2 to 2.5 years. I'm not sure exactly how long the program is there, but you're going to be busy expanding your knowledge, and we're going to all have to suffer for a little bit, because you might not be readily available to all of us like you are today. I do think you'll continue to lecture where you can and when you can and when you have time. But what's going to happen afterwards is going to be even more astounding, because as much of an impact you have on endo today, I think it's going to be tenfold when you come back out of school.
I hope so. The goal is to move forward, right? Is to always enhance the specialty, um, enhance outcomes. I'll tell you this. I'll tell you a story about me that I think it's inspiring in many ways, and that's one of the reasons why I'm also going to do endo. When I finished my radiology program, this was in 2009, I was hired to be a founding faculty for a brand new dental school in California called Western University in Pomona, which is a suburb of Los Angeles. And the person that hired me, Dr. James Coble, had a conversation with me a couple weeks before we were going to have our first class come in, to start their dental degrees. And during that conversation, I asked Dr. Coble the following, and the question was, Dr. Coble, I'm embarking into this new adventure. I'm going to start training dental students and things like that. If I wanted to be a good teacher, what would be your advice? How after 40 years of dental education that you've been involved, just give me your best advice on how to be a good teacher. And Dr. Coble takes a sip of his drinks, looks at me and goes, don't give a damn about your students. That's the best advice I can give you. And I was as surprised as you are right now.
Yeah, I mean, I like literally. I know people won't be able to see me, but I just had a look of shock on my face. That seems counterintuitive. It seems exactly opposite.
And that's exactly what I said. I was like, well, I thought you hired me to be here for the students. And he said, well, if you're going to do that, I should fire you right now because you're going to fail. And I'm like, the heck you're talking about, man? You're going to have to explain this to me. And he said, Bruno, I'll tell you this. You don't own your students anything, but you own the patients that are going to be in their chair, everything. So whenever you do, it's never about you. It's never about your students. It's always about the patients are going to be in your chair one day, and you're going to get to help them. So when I'm doing my endo residency, when I'm teaching or anything like that, all I can think about are the patients that I have never met. And one day, whatever it is that I'm doing is going to help somebody. And if you think like this, it changes your perspective. It really does. Because that conversation, I was very lucky to have it very early in my career and has completely reshaped my life. Completely reshaped.
I am so grateful that you shared that story because one, I think that perspective, that changes the way I do my job. Like it's funny, I talk about what do I do with endodontics? I'm here to support people who change people's lives through endodontic therapy, right? And going direct to the patient. I'm here to support patients. I'm here to help you, endodontists, whoever, be the best clinicians they can be because they don't have to worry about all this other stuff that I can do for them. Mm-hmm. But I think that's a great perspective to have is I'm here for their patients. I'm here because I care about those people. So that's a great perspective. That would change. That's life-changing.
Like literally changes the way you think. And when you again, if you put that first, everything else comes. Because now again, you're moving forward with a greater purpose.
Yeah.
It's to help people that you have never met. Imagine this. Right now, folks listening, one day from now, you might be helping somebody that has never even been born yet. But the knowledge that you're acquiring today, the skills that you're acquiring today, the CE that you saw today or tomorrow, it's going to help that person. And it's very, very interesting when you think like that. And it makes you hunger. It's like, what else can I learn? Because I don't know. And can be, again, you're always making a difference. And this is what Endo is. We're always making a difference. Right? I think there is no better specialty in dentistry that does that, at least from an immediate perspective. Like, it's fascinating to look at some of the reviews that I see from the practices that I visit with some of the partners that, patients are there and they walk in pain, in distress and on that kind of a feeling that, oh my God, this is the worst feeling ever. And then they leave and they see the compassions of the doctors and they see that they care and now they are out of pain. They are in the road to recovery. And that's very gratifying. So it's fantastic to see that.
Yeah, no, you're going to do great as an endodontist because the passion that you have fits right in with the passion that they have for their patients. And it's funny. I wish that's something that I hope through this podcast, even regular people who get dental care will be hearing this and listening to this, and they'll feel a little bit less, they'll have less anxiety walking into the endodontic office because we all know people stress out about that and it's like the worst thing in the world. But knowing that people like you care about them and everything that you do is for them and their comfort and to get them out of pain and to help them heal and live their best life I hope they can walk in knowing that these are the kind of people that are taking care of them. And we're all lucky to have people like you. So.
Oh yeah, I mean it's universal. I don't think anybody goes into this profession and into this sort of a clinical practice without being heavily invested in your patient's interest. Endodontics is a great profession. There's definitely different types of rewards, but in the end of the day, you go through dental school and through residency and all that to do one procedure. We're not doing multiple procedures. It's just to get really good at one procedure, which is a root canal, right? And that is very interesting. It's just one thing. You're
Yeah.
not doing 10 different things or hundreds of things that other specialties are required to do. We're just doing one, and we do it better than anybody else. And but because of that level of specialization, the specific kind of a quality that we can provide, it's extremely rewarding. So it's awesome. I love it.
I love it too. I love it too. Well, Bruno, I'm going to let you go because I know that you've got a ton to do, and I appreciate you giving me 40 minutes of your time. I didn't expect to take that much, but it's always fascinating listening to you. I could do this probably for another 5 hours. So you
It's you
are
kind.
just phenomenal to listen to. I encourage anybody to go back and listen to the AAE courses that you did that are recorded, or if they can catch you. I know you're lecturing all over the place right now. So if they can ever find you and can connect with you in one of your lectures that you're out there doing, May he goes to school, but till then he's on the lecture circuit, and then he'll be fewer and far between. So try to get in touch with you for sure and find out where you're lecturing and get in front of you because no one will regret it. So fascinating teacher, fascinating person. Blessed to have you in my life
Thank
and
you.
everybody else's. So
I
anyway,
appreciate that.
yeah.
No, it's been a pleasure. Again, I appreciate what you're doing, and to me, it's always an honor to be invited to a delightful podcast like this, and put a little bit of the passion out there for folks to get inspired and do better. Because in the end of the day, remember what we just discussed. It's not about us; it's about patients. So
It's about the patients.
that's
Yep,
right.
absolutely.
So thanks for
And
inviting me to the End of Fives. I really appreciate that.
you're very welcome. Thanks for being here. And again, it's about the patients. We'll send you off with that. Thanks, everybody, for joining. Thanks, Bruno, for coming in.